Hi again. Michael Pillinger from NYU School of Medicine here, talking about gout for Room Now. So today is Saturday at the ACR Convergence meeting, and it's been a fairly busy day for gout with a large poster session and several talks. Of course, I've got to choose something to talk about. So what I'd like to highlight here today is a bit of gout drug development. Over the past decade, there had been a lot of drug development in gout, but over the past few years, it seems to have petered off, particularly when it comes to urate lowering therapy. Currently, we're really left with allopurinol as our go-to drug, febuxostat for a limited indication, and the spectacularly effective, but not for everyone, pegloticase. And I'll be talking more about pegloticase at an upcoming roundtable discussion. Meanwhile, I wanted to highlight a couple of abstracts about a new uricosuric under development called AR882. AR882 is a potent, selective Urate 1 inhibitor and therefore a uricosuric drug. And the company sponsoring it has brought two studies to this meeting. The first one, abstract number 675, is a phase 1 study by Shen et al. This is a study of healthy subject volunteers. It's a 10-day long treatment study. And like all phase 1 studies, it's a dose-finding study. So here the doses are 25, 50, and 75 milligrams once a day. 30 adults participated, and the urate decreased, the serum urate decreased 40, 60, or 65% by dose, respectively. So it appeared that the benefit of going from 25 milligrams to 50 milligrams was very significant, from 40 to 60%. But the benefit of going from 50 to 75 milligrams was less so, from 60 to only an additional 65% decline. Of course, since this is a uricosuric, the fractional excretion of uric acid increased in the urine. So this study helped establish doses and demonstrate the short-term physiologic potency of AR882 for urate lowering in a non-gout population. What about in a gout population? That brings us to the second study, which is a phase 2A study by Ye et al. This is abstract 690. And in this study, the authors examined a group of patients with gout. They chose the 50 milligram per day dose, the one we talked about in the prior study as maybe the sweet spot, and they administered it with or without either 40 milligrams of febuxostat daily or 300 milligrams of allopurinol daily, or against febuxostat or allopurinol alone. The treatment period was 1 week, but in a 3-week crossover study that allowed all patients to get 3 different regimens. They either got the AR882, or they got the xanthine oxidase inhibitor, or they got both. There were only 20 patients in this study. 11 patients got febuxostat as the comparator, and 9 got allopurinol. To get into the study, the patients had to have a serum urate greater than 7, but the average starting urate for all the patients was about 9 milligrams per deciliter, so it was quite substantial. In this study, AR882's urate lowering capacity was genuinely impressive. 95% of the patients getting AR882 alone achieved a urate of less than 5 milligrams per deciliter, which was in this case a 53% reduction. In contrast, only 10% of the allopurinol and 25% of the febuxostat users got to less than 5 mg per deciliter. The percent of subjects achieving a urate of less than 6, a higher bar, an easier bar to achieve rather, was also markedly greater in the AR882 group. In fact, it was even higher than 95% of the patients reached that, though not surprisingly, the traditional drugs were also better at hitting this easier target than the 5 milligrams per deciliter one. The combination of AR882 with either of the xanthine oxidase inhibitors was even more impressive, often getting down to below 4 milligrams per deciliter or even lower. And AR882 was also effective in patients with mild renal disease. So this looks really promising. Now, while the authors correctly affirmed that allopurinol and febuxostat have their limitations, the case against them in this comparison was perhaps a bit overstated. For one thing, the doses of febuxostat and allopurinol used were not the optimal ones, so this comparison does stack the deck a bit in favor of AR882. We may really want to know how AR882 will stack up against allopurinol 800 milligrams or febuxostat 80 milligrams, their maximal doses. The authors state that allopurinol is only effective in a percentage of patients, but the recent nurse-led care study by Michael Doherty's group has taught us that with proper dose titration, allopurinol can be made to work in almost anyone. And the ongoing VA stop-gout study led by Jim Odell is comparing allopurinol and febuxostat in about 900 patients. And that study should provide us with additional information about just how good these two drugs are at lowering serum urate and reducing flares when properly prescribed according to ACR guidelines. The authors of the current study also point out that the use of febuxostat is limited by its black box cardiovascular warning. And that's true, but it's also true that that warning is controversial. And for more on that, I'd refer you to an editorial by Dr. Arya Abeles and myself in ACR Rheumatology Open in 2019. More importantly, a study to be presented later this week will provide accumulating evidence about febuxostat's possible cardiovascular safety. Maybe I'll discuss that issue in a later video. So overall, these very early studies suggest that AR882 is really effective at lowering serum urate and not grossly toxic in a small group of people. Of course, we need to remember that a similar URAT1 inhibitor that was highly effective, lesinurad, was approved, but only at a low dose and along with a urate-lowering agent because of associated creatinine rises. And that low dose wasn't potent enough to convince rheumatologists to embrace it, so it went off the market. We'll need to see whether AR882 avoids these problems. A new urate-lowering agent with a different profile would be really welcome. Will AR882 be that drug? Let's stay tuned for phase 2B. And keep tuning into Room Now for more reports and videos. Thanks for watching. I'll see you next time.